hospital system and our graduate medical education. And what that means is that by being placed on emergency status, all programs and program directors are really being asked to consider how we're staffing things to make sure that we're able to meet the needs of the hospital system, and making sure we're helping to provide adequate patient care. And that includes suspending some educational activities from time to time. Luckily for us, it's not going to change a whole lot, but you guys do need to know a little bit about it. And so I know the biggest fear has probably been, are we going to get pulled over to see patients in the adult hospital? Are we going to have to go over and see adult COVID patients? And that is not the case. And I want to make sure you guys hear that. It could be the case, but there's a tiered approach to how that will happen, and there's a whole process for that will happen. And that includes myself and Dr. Taylor having to approve it prior to anybody else having to do that. And so the tiered approach to it is actually involving the adult residents first and foremost, the family medicine residents, all those type of people that would be pulled first, including the psychiatry residents who have already had some internal medicine experience as opposed to you guys. And so it is very unlikely that you guys will ever be asked to go see an adult patient. That being said, if the other services are asked to provide coverage with their residents, we may be impacted on that, because family medicine might be having to pull patients or pull, residents. Emergency medicine may have to pull residents, and we may be then having to pick up those areas where they're usually on our services, whether that's the wards, the newborn nursery, clinic, PICU, and even PDR. And so I want you guys to be aware of that, and you guys will be notified well in advance if that happens. That might be the case. And so we all have to understand why this is happening, is because of the positivity rate that's happening in our local community and the capacity of beds that is going on right now. Those of you that are on the inpatient service know we've got some 30 and 40 and 50-year-olds in the Children's Hospital because there are no beds in the adult hospital and no beds in the ICU. And so that's a lot of reason why we were placed on this emergency status. It's going to be reviewed on January 22nd, and at that point in time, we'll decide if we need to continue it or if we're going to resolve it and go back to normal functioning. And so there will be more to come here in a couple of weeks, but you guys need to just be prepared that if we end up having family medicine residents, emergency medicine residents, other people pulled off of our services, you may be pulled off of an elective or another service and asked to cover where they were previously at, okay? So just be aware of that. We will be mindful of who's coming where and when, but this is all of us coming together to help the hospital system and make sure we're helping our adult colleagues take care of patients. And I think you guys would rather be seeing pediatric patients than getting pulled over to the adult hospital. So we're going to do everything in our power to make sure that that's happening. With that being the case, the other thing that we're going to do to make sure we're limiting exposure for you guys with the positivity rate in the community is, as of next week, we're going to suspend Continuity Clinic once again, and for at least a block's worth of time, ask you guys to not go to Continuity Clinic. We're going to notify your continuity preceptors today of that decision, and that is, again, something that GME has asked us to do, to be mindful of you guys as a workforce, to make sure that you guys aren't being unnecessarily exposed in your continuity clinics because you're out in the community. And so as of next week, we're asking everybody to please refrain from going to Continuity Clinic. And again, we're going to reach out to all of your preceptors to let them know that that's the case. Right now, the plan is for only a block of time, and I hope we can get back to kind of regular functioning shortly after that. But at least for a block's worth of time, we're going to avoid anybody going to Continuity Clinic. With all of the potential for people getting kind of pulled this way and that, I know there have been some questions about sick call backup, and when that schedule was coming out, we were kind of waiting to hear what was happening with this ACGME emergency status. And now that we've had a little bit of a roadmap for what potentially could happen, we're actually not going to put out a sick call backup system because we don't know how many people are going to be going different places at different times. And so everybody just has to be ready to be reached out to, and being able to tell us if you're able to help us in areas of need. Okay, so So everybody just needs to be aware of that, that you could be reached out to. And if you can't make it, that is fine. You have to let us know that. But at the same point in time, you need to be prepared. If you have a vacation schedule, do not change your vacation. If you have time away, do not change your time away at all. But please, please, please just be aware that if we do get into a crisis situation, either because of people in our program coming positive for COVID and having to be out, or because we're having to help our adult colleagues out by covering our own clinical areas, that you guys might be asked to provide sick call backup, whether you're on electives, whether you're on chalk, no matter where you are. We're just going to have to kind of be very, very attuned to the needs of each other during this little bit of time. And then the last thing that I wanted to mention to everybody has to do with the vaccination schedule. And I know I reached out to some of you guys via email. There are some significant reactions that are happening to people when it comes to getting their vaccine, especially with having some kind of low-grade fevers and body aches and almost flu-like symptoms. And so just be aware of that for when you go to get your vaccination. And if you're developing those symptoms anytime after 48 hours, you need to let employee health know. You need to let us know. You need to go and get tested to make sure it isn't a COVID exposure. If you're running fevers, I would still tell you guys to please call for employee health and get advisement from them about what you need to do and notify us, because the fevers that are happening are fairly low grade and are fairly short term. But if you are having fevers, please do call employee health to find out if you need to get tested. And similarly, what we need to be aware of is, because people are having some symptoms following their vaccination, what we're asking everybody to do is really be mindful of when you're getting those. I know that everybody is telling you guys you basically have a 4-day window to get your vaccine. That is not accurate. That was the initial kind of response and the worry about kind of logistics of everybody showing up at once and making sure things were as in tune as possible for everybody getting their vaccination. What they're really the guidelines for vaccination are that you should not get it before 17 days after your first vaccination. Really, 21 days is what most people are being told, and that is the absolute. You cannot get it before that. But anytime after that, there is no window for the back half of your vaccination. So if you need to delay getting a vaccination because you have an on-call schedule coming up, please do so. We're asking everybody, if you're within 48 hours of getting or being on call, please do not go and get your vaccination, because it's so hard to figure out if this is a vaccine related thing or if this is a COVID related thing, and then to schedule it at a different time. For your second vaccinations, they're very loose with showing up, even without scheduled appointments, and making sure that they're being aware of being able to get you guys your second vaccinations. You actually get priority as a second vaccination as opposed to your primary one. So I wanted to pass that along to you as well. So I saw something pop up in the chat here. And yeah, that's a great question. So you guys were asking about elective decisions, like if things are canceled. So at this point in time, no, we want you guys to continue to go to your electives as scheduled. And that includes your adolescent medicine rotation, DJJ, all of those places, and to continue to do that. If we run into a situation where things continue to get worse and we're having to pull people regularly, we will let you guys know if we decide to pull you guys off of electives like we did in the spring of last year. But the decision was made amongst the program leadership and Dr. Taylor that at this point in time, that we need to continue to maintain you guys' education as much as possible and give those of you that are on electives the opportunity to be on elective as much as we possibly can. Let's see here. So for sick call backup, the question is about sick call backup and needing to let people know. What I would tell you is, please just send us a brief text so that we know whether or not you're somebody to reach out to. Okay, it doesn't have to be a long involved thing. All right. If you guys have more questions, email me, text me, call me, let me know. I want you guys to have some more time to work with Dr. Stallworth. I apologize for taking up 10 minutes of you guys' time, but I'll let you guys get to the in-house test here. But I did want to pass along all that information. I know it's a lot. Just let me know if you guys have questions. Thanks, everybody.
Okay, so we'll get started. I'm going to talk fast, obviously, because we got 50 questions instead of 30 to go through now in about 45, 50 minutes. Dr. Gray's joined us, Dr. Cobb's joined us. I think Dr. Edwards joined us. So several are on, and they can throw in commentary if I misspeak or they got something to add. Let me give you that this is the background a little bit. This is the in-house test. This isn't a board review. That being said, if you look at the background of how I constructed this test, number one, Dr. Carney gave me, by going through the in-service exams and looking at categories where more people missed, like there were a lot of nephrology questions or a lot of cardiology. He told me how many questions he wanted in each category. So if you see some categories that aren't here, he felt pretty comfortable that at least within the in-service exam, he didn't need a question in that category. Number two, the questions also included the ability, no, Dr. Norton, consider the ability for me, I have incorporated questions directly that you have seen before in our board review. And even some that were less than 20 days ago or 20 days ago. I would suggest that if you miss those questions, then either I'm horrible doing the job that I need to be doing for y'all, or there's something on your end that you need to be thinking about. How do I need to adjust and look at what is being presented to me with this board review so that I can actually be sure that I'm learning and it's an educational tool for me, et cetera. So the bottom line is, I give a test, and yes, it has to be done to be looked at how you're doing and metriced accordingly, but it's an educational assessment tool for you. I'm not, it's not for me, it's for you. And so you really need to think about this and critically look at it rather than say, oh, I've done it, done, because I don't think you're going to get out of it what you need to get out of it. But again, I will leave that up to you. All right, so let's get rolling, and Whitney's going to move the slides for me, which I appreciate. Number one is a question you've seen directly before, but the bottom line to this question, remember, is that here's a kid who's tall, but he's also pubertal, if you will. He's got androgens. If his testes are small, the testosterone's not coming from there. Where would it be coming? Well, the only place of the answers given is the adrenal gland, hence congenital adrenal hyperplasia. Number two, the bottom line to this with the Lachman's negative, remember that's the test for the ACLA injury. Since it's negative, you don't have that. And this would be the worrisome thing within the stem of this question. So basically, you would just recommend a brace, ice, and rest. You're not going to do a whole lot else once you realize with that test, quote unquote, you don't have an ACL injury. And so the next step would just be to recommend brace, rest, etc. Now, number three, and again, some of these questions I am going to go a little more in depth, not because of the answer, whether you got it right or not, but because I'm going to try to teach you some elements of these questions that I tried to incorporate about good test taking skills, where some of them that you've seen before, I don't need to go back over those again. Hopefully you can do that on your own. Number three is the chief client. This is one you saw 20 days ago. And the trick here is that this is a kid with migratory arthritis. It's migratory here and then there. And really the migratory diagnosis is always rheumatic fever. And to have diagnosis of rheumatic fever, you've got to prove strep, hits, that's the answer. Remember, the anti-DNase is lupus. Why would an 8-year-old boy who's just been sick that started 2 days ago have lupus? Those are the characteristics within a question that I'm not going to say it's not possible, but push you away from an answer like lupus, okay? And so this particular answer is going to be the strep serology, et cetera. The rheumatoid factor, be just very careful anytime you see a rheumatoid factor. Remember, the rheumatoid factor only helps you sometimes in differentiating one of the 4 to 5 types. If you want to include psoriatic arthritis, that ankylosing spondylitis, okay. But from the polyarticular or the monoarticular, et cetera, that's where the rheumatoid factor may come in. Generally, that probably is not going to be the answer on the test. Number 4, I know this is a double negative in some of the answers, and I apologize, but basically the most accurate is that patients with HSP who get steroids actually tend to have less GI manifestations. And I know this is a tough question trying to look at the most accurate regarding HSP, and some of the answers have a knot in there. I got it. But you've seen this question before. This isn't a direct question that I've given you before. Number 5, another question you've seen before. Basically, this is a 3-week-old with stridor, coughing, and wheezing immediately after feeding. Immediately after feeding. Key, key, key. And sometimes you have to clue into key prepositional phrases or key adjectives or key words. And so this is a kid who has no stridor at rest. So therefore, it tends to be more of an active process. And that active process, of course, is he's aspirating, and therefore the barium swallow. Now, that's part of a swallowing study. Had swallowing study been down there and barium swallow, I don't know how to answer the question, but what a barium swallow does for you also, it does give you some anatomy to help you out. So of those answers that are there, that is going to be the question as a diagnostic study. Number 6, you've seen this question. Dr. Brown talked about it. Clubbing is not associated with chronic asthma. All the others are. Number 7, you see the low platelet count, low white count, low hemoglobin. You got many cell lines. You've got spleen. This is leukemia. And again, you've seen this question before. Remember, HSP has a normal platelet count. You can't answer HSP here at all. But looking at it, and remember, aplastic anemia typically doesn't have a spleen. So there's the difference. This is why it's leukemia versus aplastic anemia. Number 8, you always examine the testes because that's an easy place to examine for recurrence or relapse. And so this is kind of a classic question and the real reason for the answer is you can feel it. You can't feel really the liver. I mean, you can palpate, but you can't, but the testes you can feel. And so that's going to be the answer for relapse. Number 9, this should be, almost falling off a log with the 2-month-old and right kidney and pushing down and calcifications. That's a neuroblastoma, which is the right answer. Remember, Wilms would be a little bit older. The hepatoblastoma, again, it is on the right side, so there throws you a little bit. But if you're pushing a kidney down, that has to be the adrenal gland, hence neuroblastoma. Now, remember, hepatoblastoma and Wilms tumor are a common answer in a Beckwith-Wiedemann. And so you have to be a little careful, and they'll sometimes put both. But the younger the kid, the hepatoblastoma, the older the kid, the Wilms tumor. So again, age is important. Number 10, remember, you've seen this question before. I went over that. You had to deal with the direct positive Coombs, remember? And the ABO, we talked about how they slowly hemolyze, and you always follow up an ABO incompatibility at about 6 weeks, just to be sure it hadn't hemolyzed down into some areas of concern. So at 6 weeks, also 8.5 is just a little bit too low for you to say a physiologic anemia on a full-term baby. So you got a little problem there. And I understand, and I went over this about the microspherocytes, you see that word, but remember the peripheral smear of a newborn is not, it's kind of got a lot of different cells. It's, it's the newborn baby. It's got this, that, and the other. So you have to be very careful in making a diagnosis of a newborn smear. I know a smear is very important to make a diagnosis. I'm not talking anti-hemonc, but in the neonatal period, those cells can, they can have a few helmet cells, they've got kind of a potpourri of cells, if you will. The RH, remember, is Coombs positive, but they are in trouble quick, not at 6 weeks, hence.
Stalwart.
Yes.
The clinic team is asking that you slow down just a little bit.
Okay, well, I would love to, but I'm just trying to get through. So let me tell you what we'll do. I'm going to go fast to get through, then I'll come back if we have time, and then you just ask me to go back to question X, slow down, because I fear I won't get through, and I want to use your time. Would that be okay? I'll come back. Just mark a question. If I'm going too fast and you need more, I will come back to it. But I'd like to try to at least get through, because some of these questions coming up, I am going to spend more time on, as I mentioned, because there's some teaching points that I tried to put in those questions to help you with just test taking skills. Can you work with me with that? Everybody, can we work okay with that? So I will come back if we have the time.
Yes, that sounds good. Let's go.
Okay, thank you. All right, number 11, you've seen this one before. And remember, volume, volume, volume. If you don't have volume, you don't care what the sodium is. You don't care what potassium is. The patient's going to die. So here's a kid with obviously diabetes, and you're going to always restore volume first. That's the most immediate life-threatening complication is if they don't have volume, nothing else matters. I mean, really. Now, the adult world, it's a little bit different sometimes because of their heart. But in general, in kids, always remember volume. That's that 20 cc's per kg. That's why you do it. Okay, number 12. All right, now here's a question. You've seen this one before. But this is a perfect example of you turning around if you don't know the answer and asking yourself, why is it an Asian male? Why would they say that? And see, that should just tip you right quick into, they're not trying to trick you. That's in there because the answer kind of is more in line with an Asian male or an African-American male, could have been, don't misunderstand me, but they didn't say white. So you take that, then you throw the age of the patient. You know how much I've told you about the age of the patient. This is a 2-day-old male, Asian. I would stop right there. I would have covered those answers for those of you who let yourself get talked out of a right answer and say, who's icteric? Firstborn Asian male, 2 days, it's G6PD. End of story. I don't care what's coming. Because then when you get down and read it, and he's icteric, so he's got a bilirubin way outside the line of potential physiologic, which apparently a lot of you missed. I don't know who. I only got numbers of, how many people missed this. But physiologic, remember physiologic is day 3 to 5 anyhow. How could you have a 14 at day 2 and it be physiologic? So the age is so important. But in this question, everything is pointing toward G6PD. Now, in fairness, I understand that the others are associated potentially with bilirubin. I got that because that's what they're going to do. They're not going to put down appendicitis as an answer for you because they're not going to do that. So I understand all the others have it, but that's where the 2 days of age comes in. Okay. Now I know the male part here, would go, well, okay. I don't want to say, well, it's a male, just happenstance. Could have been a female. Okay. All right. I'll bite. And Gilbert's is autosomal dominant, so could go either way. Again, looking at a test like this question, okay? Since you know that, where's the family history? You see, they probably would have said, and it could have been a little bit, a little bit awkward, like, well, some question of an uncle had. I mean, they give you something to push you a little bit for family history for Gilbert's to be the answer. So once again, even though you've seen this question directly before, this is a classic question of what's there and what's not there relative to the answers that are given you, that you're given, so that you can increase getting the answer right. Okay? All right? Okay. Next. Okay. So 13 is a multiple congenital anomalies. Basically, you should have gotten this, even though you've seen this question before, down between the varicella and the amniotic, because those are the ones that kind of do skin things, the amniotic bands and whatnot. So again, trisomy 13, you would have to know what goes there. Well, that's clefting of the, where is that in the question? That's heart disease. Where's that in the question? So again, what's not there helps you. So when you get down to those two, because some of these do have some skin or extremity things, the syndactyly, you do look at the amputation, and that's what gets you on amniotic bands. Put the other way, the varicella effects are typically brain, low birth weight, scarring of the skin just from the varicella that was there. The fact that none of those are there, once again, what's not there, if you were down to those two, and that's what you should have gotten down to. If you didn't get down to one of those two, then you would have to look at this and say, I don't know what the fetal hydantoin syndrome is. I don't know trisomy 13. So go that way and be sure you improve your database. But then getting down to these two, you have to kind of walk through the question, as I just said, is what's there, what's not there, to help you increase the odds of getting the answer right. Next. Next is a 2.9 kg girl. Here's the key: normal abdominal gas pattern. Once again, you've seen this question before. So the normal abdominal gas pattern, I don't know how you went with a diaphragmatic hernia when they're telling you the abdominal gas pattern is normal. Now, that being said, I can probably see that you're trying to say, well, the pattern might be okay, but it doesn't mean that the location is okay. They're using the word pattern just to mean that there was air there and it looked right. I understand. I got it. But now you're trying to make something be what you want it to be that's not there. And you just got to be careful with that. It's an abnormal gas pattern. They're not trying to trick you by saying abdominal gas pattern is normal and the location is perfect. Then you'd be okay, because then you would know it's not diaphragmatic, because that'd be in the lung. They don't say that, but they're saying it. Yes, they are saying it by saying the abdominal gas pattern is normal. That means it's normal in all ways, shapes, and forms. So it's not a diaphragmatic hernia, okay? And then the CF doesn't apply, you know. And so the answer is cystic adenoma CAM, okay? And the bottom line here is you are a little stuck because they say left, and I know left lower is, you know, a diaphragmatic hernia, back to leg, I got it. And so that throws you a little bit. So that's where you have to go back and you have to say, but that gas pattern is normal, hence it's a CAM, okay? All right, next. Next is the 800 gram. They just asked you the side effect of surfactant. We went over this question before too. It's pulmonary hemorrhage. It can be irritating to the vasculature, and it's just pulmonary hemorrhage. Next. This is a kid, remember, green material here. That's always pathological because they're saying green in a case that's bilious, 1 week old. You know, it's you know, you've got a volvulus, you've got something. So the answer is going to be an emergent upper GI. Now, you could say, well, wait a minute, Dr. Stallworth, you know, if it's the gut and maybe he's got meconium and he could still vomit bilious, you're right, he could. But once again, you look at this question that if it's lower, why don't they talk about constipation? Why don't they mention something about he hadn't stooled? You see, that's how you look at stuff like that. You go, well, if I'm thinking it could be a bare minimum because it could be something lower, which clinically, I don't disagree. But of the best next step, because they don't mention that, A, and B, they do mention bilious vomiting, on par, it's going to be the upper GI, okay? All right, 17, I apologize for the typos on this question. That should be the protein to creatinine ratio. Most of you got this question, so I appreciate you putting up with the typos. But this is classic orthostatic proteinuria. You know that if you do a 24-hour urine, it should be less than 1 gram. None of those other things, because orthostatic proteinuria is benign. End of that story. Answer is C. Next, 18-year-old. All right. Why does this question say parent's urine is heme negative? So sometimes when you see something in a question, you might say, well, why are they telling me that? I mean, why is it even in there? Well, one of the things as this goes, because this is a routine physical exam, in other words, he's not having any problems, is you have to think about benign familial hematuria, right? Thin membrane disease, okay? And that would be a good answer. And if that one were down there, then, you know, you'd be caught if they hadn't told you that the parents were negative, because that's an autosomal dominant trait. So one of them would have to have microscopic hematuria also. But as it turns out, they didn't even put that down there, okay? So once again, when everything is negative and the kid is fine and it's 10 to 20 and the growth is fine, you know, you just start getting the sense that this is not real pathological, like complement levels where you're looking for some hypocomplement kidney disease or ultrasound where you're looking at something bad in the kidneys, or the protein because, oh my goodness, he's got some glomerulopathy. This would be your classic urine calcium creatinine ratio. You know, the number one cause of microscopic hematuria across the board is, all things being equal, is a hypercalciuria. So you want a calcium creatinine ratio. 19, it's just, and I know you either got it to kidney or lung because both of them go together, but the cause of death more likely, tough question a little bit. Don't beat yourself up if you put renal failure. I got it, because it kind of does make the pulmonary hyperplasia worse. But the bottom line is just don't make this be harder than it needs to be. This is pulmonary hyperplasia. This is Potter's sequence answer, pulmonary hyperplasia. Once again, a question you've seen before. Number 20, this is, you know, me and my my inabilities to be great in terms of teaching about sports medicine. But again, this question you've seen before, and the bottom line is to be sure that there's no joint instability. And I think most of you got this, and that's almost just kind of commonsensical based on what the answers are. Number 21, again, you've seen this not too long ago. The bottom line is the draining of spinal fluid. Hence, this is going to be a temporal bone fracture. He was in a car wreck. I think most of you got that. 22, again, you walk through this question. Remember, with the red papules over the knuckles, the Gottron's papules, you know that this is dermatomyositis, but then you've got to know what goes with dermatomyositis. Remember the heliotrope rash on the face, or you could have some capillary bleeding, or it's not really capillary breathing. It's more of a capillary abnormalities along the area of the nails. But this says bleeding when scale is removed. That's pushing you to psoriasis. So once again, knowing what a diagnosis would fit, what is there, that makes it not be the right answer if you know this is dermatomyositis. Now, if you don't, then you're in trouble. But again, not only should you read and know this based on it, but we went over this exact question not too long ago. 23, we've got a January. Please look at that month. This is pretty straightforward. You know this is RSV. That's really not the question, but it's just assessing that this kid is in respiratory failure. And with that PCO2 going up, he's got a respiratory acidosis. And based on what's given, you're going to have to immediately endotracheal intubate him. 24, again, this is just knowing your syndromes, and this is going to be Angelman's. Now, let's just look at this because I think some of you put Crete-Shot. You should know Downs. Incontinentia pigmentosa. Okay, let's look. If you know what that is, I've got to have, lightly pigmented. Is that what I'm trying to tell you? But it's not the hair, it's the skin. It's you've got a whirl on the skin for your incontinentia pigmentosa. The 22, is the catch-22 syndrome is not here. I mean, where's your calcium? Where's your seizure? That's just not there. So Angelman's and Crete-Shot could be a little bit confusing if you didn't know, but Crete-Shot, you do know it has that cry. So this is the type of example. I'm not going to say it is 100%, but this would be an example that if I got down to those two, wouldn't I maybe think the question would talk about something about the baby's crying? And the fact that that's not there, which is kind of the thing that clues you into Crete-Shot, would by default make Angelman syndrome the right answer if you can get the others out of the picture, which you should be able to. So once again, this is an example of if you can get it down to two, not only what's there, but what's not there for one answer would make that not be the right answer if that's not there. I hope I'm not putting too many triple negatives in there, but I hope you see my point, that the classic in a Crete-Shot is their cry, and it doesn't talk about that. Hence, not the right answer. Okay? Again, an example. 25, a lot of you missed 25, and I understand, and you probably got it down to C or D, or you should have based on the question. And this is where the adjective comes in. Recurring, not chronic, recurring. That means it comes and goes. Urticaria comes and goes. Molluscum comes and sits there. Now, it may eventually go away, but it doesn't go away in 1 to 2 weeks. I could argue that the rest of the question doesn't even say it's contagious molluscum, but that central punctum can get you, even though that's what you see, as opposed to an umbilication. Remember, that's the classic word, an umbilication. But I can see, as you're taking a test and you're working, that a punctum kind of sounds like an umbilication. And I got it. But if you cue yourself into words and you know those words and that's not being used, that's not the right answer. And so once again, if you couldn't get it to C or D, then you need to go back and start some dermatology again. But because you haven't seen this question before. But that's the key on this question, is to look at that adjective and let the adjective help you. Okay? All right. Next, 7-year-old was bitten by a friend's pet rat. Now, I'm going to have to tell you, I didn't even want to say this, but I'm going to have to tell you, I did get a hoot out of the fact that some of you put quarantine the rat. My God, when have you seen a rat be quarantined? I know it's a friend's rat and you're going to, but please. Okay. So I got a hoot out of that, but anyhow, that's okay. But the real trick here is rats don't transmit rabies. That's the bottom line. So no administration of rabies. Now that's not true of bats. It's not true of dogs. And yes, you're going to, but this is a rat. Now you may have to know rat bite fever if the question, but that's not the question. The real trick is to just have a understanding of rabies and basically what gives rabies. Has there ever been reported in the history of the world a rat having rabies? I don't know, maybe so, but really, or if you're going to try that, you're really going to get in trouble on this test. Okay. They're not looking for that so bizarre a potential thing that occurred. No, you know. And so just knowing that, and when y'all get ready, now I know I had to send a bird for West Nile. I know you're saying I did that. I got it. But when you get ready to quarantine a rat, you let me know. All right, let's move on. 27, 18-month-old has not had any primary teeth. Okay. Well, the classic with primary teeth is going to be the pituitary. I mean, that's your classic thing. You always worry about teeth. It may have a natal tooth, okay, but that's not eruption of your primary teeth, midline defects. Had they had hypothyroid down there instead of hyperthyroid, that'd have been troublesome for me. Hypocalcemia maybe, but they don't. They have the hyper and the hyper. Those are not it. But you have to know that. And again, if you just think about it, you've got to have some working knowledge of basic dental health, because that's basic. Remember, this is a general peds exam. And so you're going to have to know, that's something they're going to expect you to know stuff about normal teeth development. Okay. So please understand that. So there's the answer of hypopituitarism. Next, 28. All right. Now this is a question that you might have seen before. I can't remember if I've done this before. I might have resourced it elsewhere, because, and let me say, you know, were some contributors of faculties from the faculty on some of these questions, especially Dr. Holloman, Dr. Gray. But I also did prep. I went into prep questions. So these are very applicable to the exam. If you feel like they're too far out, for example, this one, I'm pretty sure I got from prep. But when you read about this question, begun to sleep through the night, what does that mean? Well, that's a prolonged fast, if you will. So you're going to get in trouble with that hypoglycemia. You look at this, it's a metabolic acidosis with an increased anion gap. At this age, 4 months, remember galactosemia, you're going to know at 2 weeks of age. That's when they start vomiting. And your classic hyperammonemic evaluation, vomiting. Is this patient vomiting? I don't think I see that. Again, the fact that it's not there might help you improve your chances of getting the answer right. But this is a classic question that goes into gluconeogenesis, and you know how you break down fats and proteins. And if you can't do that, because you're not eating, you're not getting glucose in. Yes, you can get some glycogen from glucose breakdown, but the point is with little kids, you're going to access their fat and their protein. And when they can't, then they're going to get hypoglycemic, metabolic acidosis. So this answer is to look at the plasma acetylcarnitine, the middle chain, what am I trying to say? Mid-chain CoA dehydrogenase deficiency, MCAD, okay? So that's basically the answer to this question. 29, again, if Dr. Cobb needs to say anything, this is development, but this pretty, I mean, you've got she's speaking fine, she imitates fine, but she doesn't roll over and does not, I mean, she rolls over, but she does not sit. She's 9 months, yet she can do these small little things. That's really gross motor skill delay, which is the answer. Stacy, anything you need to add to that? This is pretty straightforward. Would you agree?
Yeah, I feel like this was just a straightforward milestone one, just seeing if you guys know the 9-month milestones.
Exactly. Okay, number 30 is another one for Dr. Cobb to answer on, but you're basically having to know your milestones. Remember, we went over this in our development about when do you copy a triangle, when can you print your name? You know, those are 5-ish, but not at 4. I'm not sure about the parallel or solitary play, but kids play, you know. So the normal would be that speaks clearly in sentences. But Stacy, you want to comment?
Yeah, the big thing here to me is that with autism being such a big deal is that you really should do interactive play at 4. That's a main core milestone. So this is kind of a sneaky way by you not picking the play one for B. They were checking that because that's such a big core thing for looking for autism. But this is what they clued into is the articulation milestones, which are at 1 year old, it's 1/4 is understandable. At 2 years old, half is. At 3, it's 3/4. And at 4, it's 4/4. So it's 100%. So that was actually kind of has a nice little device to remember it, but that's how you would get to D.
Yep, and this is Gen Peds. They're going to ask questions about development. They're going to ask questions about ADHD. They're going to be asking questions about learning disability. I guarantee you, you've got to get those kind of things in your working vocabulary, if you will. Okay, 31, previously healthy, 5-year-old has coughed up blood. So previously healthy. Well, you know, cystic fibrosis, how could they say previously healthy? And I realize that CF might not be diagnosed till age 70 in some of the genotypes, but don't play that game. But for example, the previously healthy takes that out right quick. He's 5, not the classic age to aspirate. And again, the most likely would be that, you know, he's had some nosebleeds and that's the answer here. Again, he coughed, he didn't vomit. And so the gastric ulcer should be vomiting. And I know that you could say, well, mother said he coughed, but he really vomited. Okay. I know that clinical practice, you're exactly right. But on a test question, read what they've got. Okay. Don't try to make it be something that they're trying to trick you on. Okay. They even say likely expectated for this child's coughing up blood. So they use cough twice. They're not going to do that when they're really trying to say, oh, he's really vomiting. Okay. All right. So the answer there is epistaxis. 32. Now you've seen this question before, but this is your classic epiglottidic, no immunizations, the lateral neck. Remember inspiratory lateral neck, where you're going to see that supraglottic edema. All right. That's going to be the classic. The other things, you know, have to do with other diagnoses that are in the upper airway perhaps, but this stridor quickly, 24 hours, fever, child sitting up, drooling, expiratory, exhibiting inspiratory stridor, no immunizations are unknown. You get the drift. Okay, 33 is a little tough one because you just have to know a little bit more about those. But a lot of you, I think, put that intellectual impairment is seldom associated with epilepsy. I don't know if the word alone threw you off, but oh no, a lot of people with epilepsy have intellectual impairment. So I don't know if you were reading alone, meaning that, well, it can't just be the epilepsy, they have to have something else with that. So I see if you went that, if that's the reason you missed this and answer it, I got it. I got what you're saying. I can see how that was a little bit problematic. But the anticonvulsants, if you look at side effects, that's why we go to carbamazine. That's why we go to Keppra, because the others in the old days have many more side effects. Hence, the answer is going to be A. And again, phenobarbital, bad news. You don't even use this. Ketogenic, no. Valproic, not rage attacks. Remember, valproic is liver thrombocytopenia. Once again, those are the classic for valproic. So you had to get to A or B. So if you answered B, don't beat yourself up. I got it, especially if you looked at it from the way I looked at it. If you answered B because you had no idea that A was potentially right too, well, now that's a different story. And then you have to be sure you're catching on to the side effects of the medications. 34, you saw this one not too long ago. I mean, the infant's fine, and then bam, 3 hours, he's horrible. You know, that some of you put meningitis or thought through the cerebrospinal fluid gram stain. But bacterial meningitis, you get a kid who's fine and 3 hours later they're out with no. You know, bacterial meningitis doesn't just boom, hit you. You have a preamble, and then you're going to come in, you know, et cetera. So this is your classic child abuse. So the head CT is what you're going to do. Not the right age for your tox screen unless you thought there was a parent trying to kill the kid with something. I got it. But of these things, don't make this harder than it needs to be. This is a classic. He doesn't have fever. Once again, how did you put gram stain? The patient was well 3 hours ago, has no fever, and some of you are doing a spinal tap and looking for a gram stain. That just doesn't fit this at all. So, you know, be sure if you missed this or answered that, you really need to go back and do some self examination, okay? Like blood culture. Now, you don't get septic in 3 hours. I mean, go from well to septic in 3 hours. The abdominal CT, I got it. But when you look at the trick on the anterior fontanelle, that pushes you to the head CT as opposed to the abdominal CT, even though the abdominal CT could be abnormal too. But the most likely to reveal this child would be based on the information given. 35, blinking and head turning, increase in frequency. Now, this is a little tough one that you probably should have gotten it down between ask about repetitive vocalizations versus ask about stressful changes in the home. And because the setup here is they increase when he arrives home. So you're thinking, aha, he comes home and he comes to a stressful environment and then he starts these peculiar things. Okay, got it. But it doesn't say they don't occur at school. It just says they start increasing in frequency, A, and B, if you look at the question, because basically this sounds like Tourette's, which it is, you know that as the child gets tired, meaning coming home from school, the things increase in frequency. So even if you wanted to say, well, wait a minute, what's this increasing? There is a good reason for that, because anxiety, yes, but being tired increases these things, these motions, these repetitive blinking and head turning. So the answer here is repetitive vocalizations, because really they're asking you to be sure you understand Tourette's. And again, if you want to argue it based on that little he arrives home, which I got, I understand I had to, when I looked at the answers, I thought, well, wait a minute. But then if you know those things increase with being tired, that's how you can make that fit the right answer. And the other things, you know, would not be in order. Okay. All right. And let's see what else. Let's see, evaluation side of A is okay. And it says, ask about stressful changes. Well, the question goes, the next step in the evaluation. See that word evaluation. So your evaluation, yes, even though you may want to know about stressors, because that's going to impact on the thought of maybe he has Tourette's, but the next best step in the evaluation would be to ask for the repetitive vocalizations, because now you got it. You're home free. You got the diagnosis. Does that make sense? So you have to read these words and understand what they stand for. Okay. All right. Next, 36. I think most of you got this. Bordetella pertussis on this. The adolescent, you know, your immunization can wane, et cetera. 37. Okay, now some of you missed this, and I understand maybe, but I just don't understand. How do you answer bacterial meningitis when you have a normal CSF glucose, a normal protein, no organisms on gram stain, and some of you answered bacterial meningitis? I don't mean to put you down if you were one of those that did that, but you really got to go back. Either you're not reading the questions or you don't care about getting an answer right, because this is basic. This can't be bacterial meningitis. No way, Jose. I mean, she's been now sick for 4 days. Okay, and she's still alive. She's alert. You see the point? It's just not that in any way, shape, or form. Partially treated, well, where's the partial treatment? There's nothing that says she saw a doctor or she was given something over the counter by her mother. TB, real low glucose, real high protein. This is classic aseptic meningitis, right? I mean, no doubt about it. So please, if you fell into the trap on this one, there is no trap. It's your knowledge base here. You're not really, you got to work on this one. This one's almost a gimme, okay? And I'm not trying to put you down if you missed it. I'm just trying to be sure that you hear me say you got to know this. 38, again, you saw this 20 days ago. This is your classic joint reactive arthritis associated with Shigella. I think many of you put E. coli, and I realize what probably you were trying to say, well, E. coli, and he's got HUS because he's got bloody diarrhea. Okay, I like it. I see where you're going. I'm with you. This is where, though, where's the rest of the story? Where's the hematuria? Where's the rash, ergo thrombocytopenia petechiae? You see, so it just is not enough there. But I can see that basically answering E. coli really means that you don't know that Shigella has a reactive arthritis, which this classically is, with obviously the bloody diarrhea. The more concerning thing for me is if you didn't know this the first go around, you just saw this question 20 days ago. So if you're missing it, then either I'm a bad teacher or you're not paying attention to the board review and what it has to offer you. You can't just sit there and just because I say it, get it. You have to go and review. You have to go study. You have to go read about it if you miss something and write it down. Keep a ledger, and then you can review it when it's ready for the board test. 39, this one, again, 2-year-old, probably not mononucleosis, okay, not in a 2-year-old, not that you couldn't have EBV in a 2-year-old, but for classic mono, which is as opposed to some wild underlying immune defect. So basically you should have got group A strep 2-year-old, no, if you answered that, right? That's just not a 2-year-old. And you've got to deal with the conjunctivitis. So basically this is adenovirus. I can get where CMV might have gotten you because you can have a conjunctivitis with CMV, 2-year-old could have CMV. I'd say that's the second best answer. But if they're going to give you acquired CMV, they probably would be giving you splenomegaly or at least hepatomegaly. Again, not in the question. So of the two, this though, conjunctivitis, pharyngeal fever, exudates, hello, I mean, that's adenovirus, okay? Number 40, again, this is your hypocalcemia, your seizure with a cardiologist, an aortic arch, remember, truncus or coarc. So this is going to be your catch-22, right? DiGeorge syndrome. So that answer, and this question was given before. 41, you saw this question about 2 weeks ago, 3 weeks ago. This is your adolescent, what's there with ostrich slaughters. I think most of you got that, but that's just a classic thing you would know. 42, this one you've seen, remember this is that kid that has lupus, and basically you have to understand, remember the pericardial disease. If you answered electrocardiography, I got it. I mean, because you think about the decreased voltage and all that. But the most important at that point would look at that chest X-ray to see if you have that water bottle kind of cardiac silhouette, which would give it away. Electrocardiography is not bad. Now, if that had echocardiography down there, I'd have had trouble. That's probably what I'd have answered, but they don't have that down there. But the electrocardiology, albeit could be abnormal, it's not as sensitive as you would want it to be to make your diagnosis. So of the answers, it's going to be a chest radiograph. Had they said a chest CT, that'd have been a problem for me. But they say an abdominal CT. No, it's not there. It's the heart. Okay. 43, again, the 1-day-old bilious vomiting, midgut volvulus. You've seen this question. I mean, that's just your classic bilious, intussusception, not the right age. GE reflux, I think several of you answered. That's not bilious. So does that? Be sure you get those sort of things. Why would they have a stress ulcer at 1 day? No. 44, this is basically gallop, tachycardia, Ryle's, tachypnea, heart failure based on the exam. This is your intracranial AV malformation, okay? Hyperthyroid isn't bad because I know it can do some of these things like with the echocardiography, but this is a term, you've got a term newborn. They don't, hyperthyroidism and the term newborn, or without something with mother being on something or the baby having something in the neck, it just wouldn't fit this, as opposed to somebody older that you might get into. So the fact that this is a term newborn, pay attention to the age of the patient. He's born at term. He had this AV malformation in utero too. You know, it just didn't occur. So you get the drift, okay? All right, 45, the key is the hyperammonemia, vomiting. You know that within that, that's gonna be in your urea cycle defect, which I agree, you know, or in your fatty metabolism problems. I mean, you're kind of in that category. I was going to look this up and I hadn't. So galactosemia, no. Maple syrup urine, no. Methylmalonic, no. I mean, that doesn't fit. So you're down to the arginosuccinic, and I can understand why you would add that, thinking, well, this is a urea cycle. It's part of the urea cycle, and I'm with you. So I don't think that's a bad answer. But I don't think they have an elevated ammonia. I could be wrong. I could certainly be wrong, but I know the hypoglycemia. Remember, we're back to the hypoglycemia with that question a while ago, where if you can't break down your fats, you're going to get hypoglycemic. So that hypoglycemia with the hyperammonemia and the neutropenia pushes you into the MCAD. But in fairness, if you answered arginosuccinic, at least you were in the category. And I understand why you would have gotten a little caught on that. And so this is a little bit of a tough deal between the two. And the best I got is to please look up the ammonia, but I do know the hypoglycemia goes more with the MCAD. 46, all right, this is a kid, Coca-Cola colored urine, no clots, you know, this is protein blood, you know, she's got what? She's got an AGN, and so most likely post-strep or something, and you're going to look at, therefore, her getting a complement level because it's going to be a hypocomplement GN. None of those other things would fit that, okay? 47, now we're moving into Dr. Gray's question she gave me at the end here. So Maggie, if you want to chime in, if I don't do the right job. This is a 6-year-old, this is just database. You just have to know what causes myocarditis. And you know, remember, it's Coxsackie and adeno. Those are your classic two. So that's just a database question. 48, you get into this, where are you hearing the murmur? Because you got continuous, well, okay, PDA maybe, aortic insufficiency incontinuous, peripheral pulmonic artery branch incontinuous, carotid bruit typically, maybe not as continuous, and Dr. Gray can help us here. So you might get just to the continuous part with the PDA versus the venous hum, but then look where it's heard. The right upper sternal border, under the clavicle, turn the neck. This is a venous hum. Maggie, do you need to comment on that more?
Yeah, no, the location, the fact that it's continuous and then it getting diminished when you turn the head or have the patient lay down are pathognomonic for venous hum.
Okay. Number 49 is biliary atresia, means hyperbilirubinemia. And again, this might be biliary atresia, maybe biliary hypoplasia, could go either way with this, but you've got the pointed chin, the eyes, this is syndromic, and the murmur. Obviously, you could add in some vertebral problems if you want, but this of these would be classic Alagille syndrome. Williams doesn't have anything to do with biliary atresia or hypoplasia. Noonan's doesn't. The George doesn't. I don't think Charge does. Where's the L for liver? So this is Alagille. And then the last question, this one was a little tough for me because I got it down to 2. And so if you read this, it's the importance of the family history of this uncle at 34. And so the trick here is, and with the coronary artery being normal and echo being normal, it kind of pushes you into a arrhythmic problem. So the coronary artery vasospasm comes out and certainly doesn't sound very benign if he's falling out and the family history there. So the idiopathic ventricular fibrillation, I don't know what that is other than it's idiopathic. So I got caught on between A and D because Brugada syndrome is within that spectrum, if you will, of a problem related to electrical rhythm, etc. But the way I went to get this right, and then Dr. Gray can comment better, is what is the most likely? Well, long QT is much more common than Brugada, number 1. Number 2, Brugada, though, does occur more in males, and he is a male, so you got caught there a little bit. But I just had to go with the most likely of the 2, and hence that's why I answered long QT. Now, there may be another thing in here that's going to help us out that I just don't know, so I'm going to let Dr. Gray help us out with the right answer being long QT.
Yeah, a couple things. So you're right, just thinking about the overall frequency of long QT versus Brugada. The setup, the patient's episode, either one of those could really be long QT versus Brugada, but long QT is going to be significantly more common than Brugada. And then the history of died while swimming, that's a huge red flag for long QT. So if you have a history of a patient, family member dying while swimming, they were a known good swimmer, that's really suspicious for long QT in particular.
Okay, so I just saw one chat, Kelly. I don't. Dr. Carney has those the percentages. So you need to see him for the percentages. Is that what you were asking me, or what the average was, or something? Any of the metrics, I think Dr. Carney is where you need to go. If that's Kelly, is that what you're asking me? Okay. I don't know. All right. So,
so just one other note on 50 is that several of the AEDs actually can prolong your QT.
Okay, right.
Side effect. So that kind of in there too might also make you be thinking along the long QT.
I think that's a great, that's a great point.
Yeah. The other thing to think about with the family member on the anti-epileptic medication is that a lot of time syncope gets misdiagnosed as seizures. So the uncle may have had long QT syndrome and was having episodes of sudden cardiac arrest that was misdiagnosed as seizures.
And the other big one for medication with prompt QT, and Maggie, correct me if I'm wrong, is the Zofran. Be careful about that antiemetic, remember? And that's where you get in trouble. People with
and methadone.
And methadone. So people with congenital heart repair, kids that have had congenital heart repair and whatnot, you have to be careful to stay away from Zofran, which is a commonly used drug. No, I would stay away from that if I were you. Okay, so hopefully this helped. Again, I think you can ask Dr. Carney about your results and how that stacks up. I just don't know those. Any quick questions I can help for the good of the group? And I apologize for going fast, but at least we got through, which was at least one of my main goals. Anybody with another quick question? I know the chat's here. Whitney, can you help me with the chat? You know how limited I am. Is there anything from the chat that I need to respond to right quick?
Not that I see.
Nothing that you see?
Everybody should have gotten an email that had their score to this test in it. So if you turned your test in, you got an email from me this morning that had your score in it.
Oh, okay. Well, there you go. I didn't know that. Okay. All right. I hope this has been of some help. Again, I hope maybe it gave you a little bit of a reality check that you got to somehow look at the board review and questions I go over And if you don't understand them because I go too fast, then, write them down and talk to somebody and see me, and maybe I can go over that question with you. Because it is a little bit disheartening when I see y'all missing many times a question directly. And I know that you're probably thinking he's trying to trick me and he gave the question, he changed the word, so I got to change the answer. Please don't get into that mindset. Walk into it. This is a general PEDS exam. There may be a question with a trick in it. I'm not going to say there isn't. But I think when you see coughing up blood, coughing up blood, coughing up blood, don't try to make it be vomiting blood. I mean, I know in clinical practice it could be, but on a test, try not to do that. Okay, so hopefully this was of help. We're about 5 minutes over, but see me if there are any questions or problems. And thanks for my co-host here and Whitney for working with us on this. Okay. Bye.
Thank you, Dr. Stallworth.
You're welcome.